we get into actual antibiotic susceptibility testing, talk about some of the important concepts in antibiotic stewardship, what that means. First of all, antibiotic stewardship begins with the recognition that, yeah, you've got to use antibiotics. You get that, but know that there are problems associated with antibiotic use. The more you know about the antibiotics you're using, why you're using them, and if the bacteria that are causing the infections in your patient are susceptible to them, the better off you will be in the grand scheme of things. Okay, so in terms of what kind of damage can be caused by antibiotics, we're talking about, depending on the antibiotic, wiping out your normal flora, the vast majority of bacteria that aren't causing any problems to the patient whatsoever. This is particularly true with one niche in particular, the gut microbiota. And this is definitely true when you're taking oral antibiotics that have to go into the GI tract in order to be absorbed by the body. So you wanted to give extra consideration for those. And you also want to think about antibiotic resistance as well. When you are treating someone with antibiotics and you do not clear the entire infection, that can select for antibiotic resistant strains. When you have like populations in the hundreds of millions or billions of bacterial cells, know that a small percentage of those bacteria, like 1 in 100,000, can still be significant if you kill off 99.99% of them. You still get sizable populations that can be selected for. And then they have the opportunity to outgrow and cause infections and spread antibiotic resistance factors. So that's kind of the rub. And that said, we've talked about this before, but when you have really serious bacterial infections or any other kind of infections, you got to do what you got to do. There's a recognition that you have to do that. So sometimes that does involve not just one single broad spectrum antibiotic, but last-ditch effort, multiple broad spectrum antibiotics, administering all of those. And again, like more broad spectrum antibiotics used, the bigger the consequences will be for your commensal population of bacteria. When you have the information, which you don't always, hope you will eventually get there, when you know exactly what the pathogen is that's causing the infection, then hopefully you can start looking at some of those narrow spectrum antibiotic choices and use those preferentially. They will do the same thing, have the same effect, but not have the collateral damage that you would get with broad spectrum antibiotics. In terms of the principles of antibiotic susceptibility testing, again, you're going in there and you don't make any assumptions about the resistance profiles of bacteria that are causing infection. So you order antibiotic susceptibility testing. It's not always necessary. For example, a couple of cases where it wouldn't necessarily be absolutely essential to order ASTs. One would be if you put somebody on an empiric therapy and that empiric therapy is working. Perhaps then AST testing may not be necessary, but it's still probably good practice if you could do it. Even if that patient's improving, it might be early on in selecting for resistant bacteria. And also the data that you generate from submitting that isolate to the lab and getting AST data is useful for epidemiology purposes as well. So if it's a serious infection, it's probably worthwhile to submit for AST testing, even if that antibiotic is effective. This is another important point. When you do have a high likelihood of having resistant strains, for example, if you have an escape pathogen, remember we talked about that acronym escape pathogen? Those are bacteria that are by definition associated with heavy multi-drug resistance, high likelihood of resistance to whatever antibiotics, like multiple classes of antibiotics. If you have an escape pathogen or something else like that, that's going to be a variable susceptibility profile for this bacteria. So AST testing would be important for those as well. I also remember early on when I got to IPAP, I was talking to a Navy IEC corpsman who was telling me about, before he got to IPAP, he had no idea what the mechanism of actions were for any of the antibiotics that he was prescribing patients. And it blew my mind because that's the first thing we think of is antibiotic susceptibility. But he didn't know mechanisms, so he was just throwing prescriptions at patients. And then he was getting treatment failures. Like, treatment failed to clear up an infection, and he just prescribed another. He didn't know what he was prescribing. He didn't know why. and it's failing. He's talking like 3, 4 rounds of failure. This is crazy to me, right? Why you wouldn't submit that specimen for ID and AST and get a definitive result. So if you're getting a lot of treatment failures, chances are you were not cycling a good antibiotic. For all of this, we're going to talk about a couple major techniques, but it goes without saying you do have extremely rigid quality control procedures that are involved with antibiotic susceptibility testing. You need it to be precise, you need it to be reliable for that provider or clinician. So yeah, it's very difficult, but you need that to be like good information for the provider, good useful information. All right, so how is this communicated and how is this understood when we look at whether or not isolates are resistant to antibiotics? The most common way we have of communicating resistance versus susceptibility is a term called the minimum inhibitory concentration, or the MIC. By definition, the MIC is the lowest concentration of an antibiotic that can inhibit visible growth of a particular bacterium in vitro. So why does it matter if it's in vitro? Would that have any potential problems for interpretation, do you think? Like what kind of issues would that potentially cause?
It doesn't account for all the variables inside the body.
Yeah, exactly. So if you're a bacterial cell, let's say you're E. coli, and you're an E. coli that's causing a UTI, or you're infecting the bladder, you're going to have a lot of host factors coming at you. And those host factors are going to be sensed by those bacterial cells, and there will be a response. None of that is present if you're growing up that E. coli with some sort of microwell plate or microwell plate. So the response might be a little bit different. You might have antibiotic resistance factors that are on an inducible operon, which we know might not get expressed under certain conditions. So these are things we have to account for. Meanwhile, when we're doing this in vitro testing in the lab, that patient, that real live patient, is experiencing that interaction directly with that bacteria. So, yes, sir.
Can you I'm lost on what vitro means.
Yeah, in vitro. So in vitro means experimentally done, artificial, in the lab. When you order an ID and AST, we're growing up that bacteria in vitro outside the human body. But that same bacterial isolate is sitting over there in your patient growing in vivo in that body. And then when you treat that patient with amikacin or some antibiotic, that is an in vivo response that patient's bacteria is having to that antibiotic. But while you're doing AST testing artificially in the lab, that's an in vitro response to that same antibiotic. You take out all the host factors that would be important for that bacteria. So it's a little bit of a difference there, but nonetheless, like these bacteria do respond to increasing concentrations of antibiotics. And that's what the MIC is. It's the lowest amount of antibiotic you can use in order to inhibit bacterial growth. It is different for each bug-drug combo. Example here, we're talking about the same bug, we're talking about Staph aureus, and the drug that you're using is vancomycin. Vancomycin is a very popular drug of choice for gram-positives, but in this example we have two different isolates. Let's say isolate A came from one inpatient and isolate B came from an outpatient. You'd think because they're both Staph aureus they would have the same resistance profile to this drug. But not necessarily the case, right? Because you have spread of antibiotic resistance genes. So you could have a heterogeneous resistance profile between different isolates. That's why you always have to do AST testing per isolate. Okay, even if it comes out of the same patient. Let's say you get recurrent UTIs, and your UTIs are caused by Staph saprophyticus, which are gram-positive. You go in, you got a really severe UTI, they order AST testing, you get an antibiotic prescribed to you, it clears up the infection, and then you come back a year later, you have the same organism, still Staph saprophyticus. You still have to do another AST. A year has passed, time has passed. That organism could be fundamentally different at that time. Okay. So this example up here illustrates a pretty small change, but this is the MIC. This is expressed in mg per mil or micrograms per mil, or I'm sorry, mg per liter or micrograms per mil. But small change here, but those changes can be appreciable depending on the environment of those particular bacteria. If you do get an MIC, let's say you're a physician and the lab reports back that you have an MIC of 0.57 mg per liter, right? That's just data. It's still not information. It still doesn't tell you whether or not that's safe or good to use. What tells you whether or not that would be a good idea to use that antibiotic, that vancomycin, for example, would be these guidelines. These are called the Clinical Breakpoint Guidelines. So those are published by CLSI, this organization, Clinical Laboratory Standards Institute, and they give you kind of like a translation of what those MICs mean in terms of whether or not you can use that antibiotic for that bug, that bug-drug combo, whether that's safe. Okay, and we'll go into that in a little bit more detail in a second there, but with these two particular examples, we've got an MIC for isolate A, 0.57 mg per liter, and then we've got one of 0.42 mg per liter. What do you guys think about this? Which one would be more susceptible to vancomycin?
To like be destroyed by it or
Inhibited.
be inhibited by
Yeah, because what's the definition of minimum inhibitory concentration? It's all
the lowest concentration?
exactly. So which isolate is more susceptible?
B.
Yes, and why? Exactly. So it takes less drug to inhibit the growth of that Staph aureus isolate. Yes, that's the thinking. Exactly. So generally, if an organism, if an isolate has a lower MIC, great. Some of them, if they're super resistant, like you've got a really nasty E. coli isolate that is expressing extended spectrum beta-lactamases, then you might have super high MICs. Yes, ma'am?
For those like antimicrobial drug, is that like some sort of like universal drug that have all kinds of like mechanism to target the different type of virus or bacteria that we're talking about, or is just they attack just one particular pathway?
We're talking about all the antibiotic, like let's just say we're talking about bacteria for the purposes of this lecture, although there's antivirals and antiparasitics and antifungals as well. But for antibiotic drugs targeting bacteria, we're talking about the classes that we have currently available in our arsenal against bacteria. And those were what we were talking about last week. So the classes of antibiotics that will be interfering with peptidoglycan synthesis in the cell wall, right? Drugs that interfere with cell membranes like colistin, polymyxin B, that sort of thing. So that's why we study classes. But if you're not familiar with antibiotics, this is the beginning of that journey. It will be a long journey, but it's good information. So,
On the clinical side, do they always test patients' specimen, or is there just a generic set of antibiotics where hey, they could be symptoms, so give them this nick and we'll see how it goes? Is it like that?
yeah, so that would be more. So what you're just so he asked whether or not you ever just prescribe based on symptomology and presentation, and the answer is yes. That's empiric. That's a definition of empiric treatment. The patient comes in, you don't have time to order IVs or ASTs, and this is sort of kind of the training you'll get when you get to infectious diseases as a junior. They'll tell you, and it'll sort of like continue on with what you're learning in this course, and that'll be after you've had Pharm 1. So it'll synthesize everything you learn in Pharm 1 next semester with everything you learn in microbiology this semester. And then the types of questions will be like, patient is presenting like this. You sometimes are given the ID, but oftentimes not. So you're forced to make an empiric diagnosis and then prescribe empirically antibiotics that have a high likelihood of succeeding to clear that infection.
Like a criteria?
Yeah.
Have you ever heard of Centaur criteria?
Yeah, what's the Centaur criteria for?
It's the criteria to determine if you're going to treat strep or not.
Exactly.
So like lack of cough, fever,
Age.
age, anterior cervical lymphadenopathy, and tonsillectomy.
Yeah.
If you have those things, then we have a high likelihood it's going to be strep. We can treat for strep in the field.
Yeah, exactly. And I don't know, like there are other scoring matrices that are applied sometimes to evaluate patients when you don't have an extra day or two, or when you just need to get them started on empiric therapy and then get the AST results and then tweak and adjust as needed. But yeah, we do have empiric therapy, and it is absolutely, even I, as a microbiologist who kind of hates antibiotics, recognizes that you gotta use antibiotics empirically sometimes. Okay, so in terms of those breakpoints and what they mean, we've got 3 categories. We try to keep it as clean as possible. In the United States, these are the 3 categories we use under CLSI. Europeans adhere to a system called the UCAS system, which is a little bit different than ours. But here, we keep, say again? How European?
They have to use it.
Oh, yeah, I know. And you know what's fun is when you get on these conferences where you have people from CLSI and UCAS together in the same room, debating about who has the better breakpoints and better science behind it. Nerds. So, in the US, CLSI has these nice 3 intuitive, easy to understand, like every provider can look at SIR and kind of know what these mean. Especially S and R, these are kind of intuitive. Intermediate's a little bit trickier. But if your result is susceptible, that means you have a pretty good, you're expected to have a success rate with using that particular antibiotic against that particular bacterium. If it's resistant, do not use. It's not going to work. If it didn't work in vitro, it's probably not going to work in vivo in your patient. And intermediate is tricky. If you can use something else, obviously use something else. And if you've got to use this, expect that you're going to have to use it probably at a higher dosage than you'd normally like, which might be really bad if there's a poor selective toxicity profile or something like that. And also, oftentimes in consultation with an ID doc. So as much as possible, try to stay away from prescribing antibiotics that have returned AST results with an intermediate breakpoint. Be avoided. Okay, so a little bit more information on what breakpoints are. Just like I said, they predict the likelihood of successful treatment if you use that particular antibiotic on that particular bacterium. These are things that you're going to be learning about extensively in pharm, but just as a little bit of a primer so we can communicate about how AST works, AST testing works. We've got the PK, pharmacokinetics, kinetics of the drug. And this is more or less considering it from the host side. So, is it an oral antibiotic? Does it have to be absorbed by your gut in order to be released into the body? Is it IM? Is it IV? How is it being administered? Is it being metabolized through the liver? How is it being eliminated in the body? All of these things are relevant for breakpoints, establishing those breakpoints. Is it going to work or not? Pharmacodynamics, this is looking at those breakpoints a little bit more from the perspective of the bacteria themselves. This is kind of going to that question you asked about antibiotics. But this is why we study classes of antibiotics and what their mechanisms of action are. Is it an antibiotic that is super broad spectrum that is going to be targeting like the 50S large subunit of bacterial ribosomes? Is it going to be super narrow spectrum antibiotics? Stuff like that feed into the pharmacodynamics of different antibiotics. And then all these breakpoints are fueled by huge amounts of clinical data. When you are moving an antibiotic candidate through the regulatory pipeline, the FDA and the USDA, before it gets released into the market, you have to have massive amounts of data on the efficacy of these drugs, including the PK, the PD, how it's performing against all sorts of different types of bacteria. And we need this data to be in vitro as well as in vivo. We need data from human populations on the efficacy of all of this. This is constantly updated. CLSI constantly updates its breakpoints. It's never static. Antibiotic resistance trends change all the time. And they also change region to region depending on the antibiotic practices, sometimes all the way down to hospitals and sometimes even down to wards in hospitals. So you can see antibiotic resistance profiles changing. And I'll show you the very last slide why that's important sometimes. And this last bullet can be kind of grouped a little bit, I guess, under pharmacokinetics, but knowing where that patient's infection is, whether they have a bone infection or meningitis again, like you just need to know whether or not that antibiotic has penetrating power to those sites of infection. Patient variability, also pretty intuitive. If you have a patient whose BMI is like 35, you might not be able to dose that patient with standard dose. They might need a higher concentration. A whole bunch of things. Age, extreme age of the patient, super young, super old. Immunocompromised, we've talked about this before. Why do we care about the immune status of a patient before we pick an antibiotic for them? Anybody?
We get rid of what they have left.
Yeah, but what about their immune system itself? Like, if they have a crappy immune system, might that be limiting in terms of what types of antibiotics we can give them? Yeah, so if you have a bacteriostatic antibiotic that's otherwise would be perfect for a healthy immunocompetent person, you probably still shouldn't use it for an immunocompromised person because it's relying on the assumption that they have an immune system intact that can mop up the rest of what you do with that antibiotic. So that's important as well. Yes, sir. It depends. It completely depends. Yeah. You kind of have to study these case by case, situation by situation. Okay, so this should be pretty easy at this point. There's just an example here. We've got an infectious isolate. In this case, this example is Escherichia coli, E. coli. And we're testing some generic antibiotics, so antibiotic X against it. These are our breakpoints. So now we're going to ask the lab. We've already got the ID. We know it's E. coli. But now we're going to ask the lab to do an AST test for us. And the lab comes back and says it has an MIC of 1 microgram per mil. What do you guys think? Can we use that antibiotic X or no? Absolutely. Why? Exactly. It is under that threshold amount for that antibiotic. It's under 2 micrograms per mil, so it easily clears that. Let's say you submit another isolate of E. coli to the lab, but this isolate is packing some serious antibiotic resistance genes. It comes back and returns with an MIC of 16 micrograms per mil. Can you use antibiotic X? No, because what's the threshold for resistance? For that particular breakpoint, for that bug-drug combo, it's going to be 8. Okay, so makes sense, right? Yes, sir.
So, in my head, I think like more than 8, it's going to be great because it's going to kill it if we go up higher than it. But why is that again?
Yeah, so
That's not good.
think about the antibiotic. Let's talk about vancomycin just for a specific example in terms of potency. If you have something with potent killing power, it means that you use less of it to kill that thing. And less is good because that antibiotic, generally, it's not good for the host either. So it's like a little, this is a terrible analogy, but it's like a little bit of poison, okay? It's not good for you. You don't want a lot of it. The less you can get away with using, the better, okay? If you have a super resistant bug and it's higher than the MIC, like the break point is higher than the MIC, what you'd be asked to do clinically is prescribe that patient more of something that is what's considered safe and tolerable for them to use. So more is worse, less is better, if that makes sense.
And because it's above that 8, that's why it's resistant.
Yeah.
Because
Yeah.
resistant is at 8.
I mean, with some antibiotics, like, remember when we were talking about atypical bacteria? We were talking about the definition of atypical bacteria. They're small, but they've got funky cell walls, right? With mycoplasma, for example, has no cell wall at all, so it has no peptidoglycan. What would happen if you tried to treat a patient with pneumonia caused by Mycoplasma pneumoniae with an antibiotic like some beta-lactam that targets peptidoglycan synthesis? You have zero efficacy. I mean, you could administer a tub full of that beta-lactam, that penicillin or carbapenem, and it's not going to do anything. Okay, so does that make sense? Yes, sir.
Is this is like this example showing the key for susceptible, intermediate, and resistant for all bacteria, or is this just specific to E. coli?
Specific, not just for E. coli, but for that isolate. This guideline is for E. coli. Sorry, like So what you do is you look up your little CLSI breakpoint guidance for E. coli and that drug, and that's what you're going to see. But you do the testing for each isolate you come across.
Gotcha.
Yes, because that could change. Yes, sir.
Sorry, as far as for, I know it's probably gonna be dependent, but you know how you're talking, if the resistance is too high, you can still like go to another doctor, because you still need to use it. Infectious disease doctor, things like that.
Oh, if you have an intermediate result, like if your MIC is in that intermediate range of a breakpoint.
But,
you
yeah,
can
but with this
consult with an
example,
IPI.
say you run out of options, right, like you theoretically still, like, is there a limit to where even though it's going way past that resistance, so like a kind of generalized, this is like a no-go regardless of any situation?
Maybe. So that's a great question, and these are real questions that people do face in reality. So, scenario. You've got a patient with a pen strep allergy, so boom, right away, you can't use pen strep antibiotics, right? That eliminates some. They're immunocompromised, so now get rid of all the bacteriostatic choices. Their ID comes back and it's a gram positive, so now you can't use any of the amino acid or antibiotics that are against gram negatives or whatever. So your options keep shrinking, and now your AST results come back, and it turns out that this isolate is resistant to multiple classes of antibiotics. You have a pile-on of effects going on, and your options start getting really, really narrow. There are isolates that have so much resistance that they are resistant to practically everything out there. So is an ID consult going to be necessary? Probably. That's not something you're going to want to deal with yourself. But yeah, that's like a real-world problem that we're facing right now. The emergence of extremely drug-resistant isolates of bacteria, where you have almost no, they're called superbugs. You have very few options to treat them, and you might need to treat at higher dosages with intermediate results. Yes, sir.
So, I guess just to clarify, this is a separate data point then from what you would use as far as your maximum safe dosage or what you would actually prescribe. Say, as an example, say the MIC that comes back on this is 16 mics per mil, but your maximum safe dose for whatever that agent is, even though it's a resistant strain of the micro, was like 25 mics per mil, so you can still have efficacy. Or would that, is that scale sliding based off of the antimicrobial agent you would use?
Yeah, the breakpoints are designed to be accounting for all the patient safety data, so it should account for that.
Okay.
Yeah. And there was another question over here somewhere. Yeah. Yes, ma'am. Yeah, that's a great question. So she's asking about the timeline of making these decisions. If you're like my previous student at maybe at Corman, you're just like willy-nilly prescribing antibiotics as you go and waiting until the patient fails treatment. And the answer is it also depends on the severity of the initial infection, right? If you're talking about just a really severe respiratory infection or maybe a kind of bad UTI, those are unpleasant. But evaluating the clinical picture of your patient, what kind of their urgency of their situation, it might not require an immediate prescription, so you might have some time. When you're talking about really life-threatening, terrible scenarios where your patient is septic or where they have meningitis or something that is life-threatening like that, you're going to need to go to empiric therapy more often than not. That isolate might be resistant, you don't know, you have to wait until the ID-AST results come back. But in the meantime, you give it all you got and you accept the consequences because that patient is going to die. In terms of time course, empiric therapy can start kind of right away as soon as you've evaluated that patient and you know what you're going to do. If you're convinced that the diagnosis is meningitis, or hopefully bacterial meningitis, then you can start your empiric therapy there. And then hopefully you get your specimens from the patient, and you can get you can start submitting CSF samples and get the IDs and ASTs, and then adjust as needed later. Okay. So let's talk about these common methods of generating ASTs. We've got at least, these are two super common methods. There are other methods as well. The disk diffusion assay is one that we'll talk about in the microbiology series. Both of these are common in the United States, in US labs that are well funded. So I've worked in medicines that have done both of these. Oftentimes you have labs that can do both, not just one of these different methods. And with both of these, you can also set these up where they're automated. So you can do these either by reading the results yourself. I'll teach you how to interpret those. Or there are high throughput platforms that can sit there and scan these and give you the results and the data directly. Okay, so first we'll talk about the disk diffusion assay, this one on the left here. With this assay, the principle here is that you are taking your specific isolate, which has already probably had an ID, so let's keep with the E. coli theme. You have an E. coli that you've taken from your patient, it's causing some infection, diarrheal infection, UTI, whatever. So you take that bacterial isolate and you spread it out on an agar plate, usually through a type of media called Mueller-Hinton media. And you spread it out in such a way where you get a lawn like this, except for it's going to be all over the place. You're not streaking for isolation. You want like that plate to be carpeted with that bacteria when you're setting it up. So there's no growth initially, you just seed the plate. And then you drop these little small pieces of paper, they're membrane discs, that are impregnated with antibiotics at a certain concentration onto that plate as you're setting up before you put it in the incubator. You can put 1 disc on there, you can put 8 on there, depends on how many antibiotics you want to test. But you set that up and then you stick it in the incubator for overnight growth, let those bacteria grow up overnight. And as the bacteria are growing, the antibiotics that are impregnated into that disc will leach out into the agar and create, if their work against that bacteria, they'll create a zone of inhibition as that bacteria grows up. That zone of inhibition is proportional to the efficacy of that drug against that bug. Okay, so this is something you can actually measure. You literally take a ruler and measure the diameter of the zone of inhibition when you come to lab the next morning and you read these disk diffusion assays. Okay, so bigger the zone, the more effective the antibiotic. If you look closely, these little discs have the name of the specific antibiotic on them. This is mupirocin, MUP, VA, that's probably vancomycin, et cetera, ticoplanin, whatever. So if this is mupirocin, and this is cefoxitin, which one do you think is more effective against that E. coli that you grew up overnight? The mupirocin, right, because it has a bigger zone of inhibition around it. Exactly. But these two, when you start measuring out your diameters, so you record them down, this one is like 16 millimeters, this one is 12 millimeters, this one is whatever, 8 millimeters. You record that down, and then you look up the breakpoints, right? Because otherwise this is data and not information. So you look that up, and you see whether or not that 16 millimeter diameter is sensitive, intermediate, or resistant. Okay, same deal. So let's try this as a little bit of an exercise. We have 7 different antibiotics on this plate. This is bacteria X, let's just say it's still E. coli. It's a big plate. Ignore number 1 because I don't know how they interpreted this, but the way this plate is set up, with these other 6 antibiotics, 2, 3, 4, 5, 6, and 7 is in the middle there, they put the measurements of those zones of inhibition on the plate, and then they overlaid in black outline the zone of inhibition, and in red, that's your break point, okay? So if the zone of inhibition is greater than your break point, you are good to go. If your zone of inhibition is smaller than that red break point, not good to go, okay, resistant. So let's have a crack at this and see if we understand what's going on. And if it's orange, that means it's in this intermediate range. So there's that first one. So we're talking about amikacin. We'll kind of walk through this one together. We've got a zone of inhibition. It looks like the red is on the interior. The zone of inhibition is about 21 millimeters, so just a little bit bigger. And when they look that up in the CLSI guidelines, it has an intermediate range. So you call that intermediate for amikacin. Okay. What about number 3? Number 3, we have ciprofloxacin. It's a fluoroquinolone. What do you guys see in terms of the break point versus the zone of inhibition for that? Susceptible. So we can use it, right? Yes.
So you want the black line to be larger than the red.
Yeah, but know that this is these are imaginary things. You'd have to be looking up that, yes. But yeah, you want the zone of inhibition to be bigger than that break point. Yep. Okay, so that's ciprofloxacin. This particular isolate is sensitive to cipro. What about number 4? This is ceftazidime. It's a 3rd generation cephalosporin. Why is it resistant? Yeah. Wait, can you translate? Can you translate that?
The zone of inhibition is smaller than the break.
Exactly. The zone of inhibition is smaller than the break point for number 4. It is resistant, and it's not expected to work against that 3rd generation cephalosporin. All right. What about this? Is a 4th generation cephalosporin, ceftazidime. Number 4. Oh, we just did that one. Sorry, my bad. Number 5, peptase. That's a drug combo. You said ditto. Okay, and because what is bigger than what?
What Jan said, zone of inhibition is larger than the break, smaller than the break.
Zone of inhibition is smaller than the break point, so it is SI or R. It is R. So would you use peptase for that isolate? No. And the only reason why I'm going through this with you guys is just muscle memory, just to get used to saying the words and understanding what they mean. What about number 6, cefepime? That's the 4th gen cephalosporin.
Same. Even though it's like.
Okay.
What Jan said. What
That's
Jan said, what
fine.
Dakota said.
Okay, so the zone of inhibition is smaller than the break point. Not good enough. It could be resistant. Can't use it. And then lastly, we've got number 7, meropenem. That's a carbapenem. So targeting beta-lactam. What's going on here?
There's overlap.
It's a little tricky. You said, what did you say?
It has a wide break point,
Yeah, it should be susceptible. I mean, there's all this, I assume this is an artificial intermediate zone that they've indicated here, and you can see the zone of inhibition is well outside of that. So I would assume that would be susceptible. Yep, susceptible, good job. And one, just ignore, I'm not sure how they interpreted that gentamicin. But it makes sense, distribution assays, not so bad. Yes, sir.
So, I don't really see much of a difference between 2 and 7.
In terms of like,
So, the red line has to be outside of it for it to be susceptible, right? Outside of the diameter of the zone of inhibition?
the red line being what? Let's use our technical words.
break
Break point.
Yeah.
Yeah. So the break point has to be of a wider diameter than the zone of inhibition, but for 2 and 7, they look the same.
Flip.
Okay, flip.
The black zone of inhibition has to be greater than the small red one.
Stop
The
saying
break
red
point.
line.
Well, to help them out.
Okay,
Yeah,
okay.
the red is the break point,
Yeah.
and then the black is the zone of inhibition. The zone of inhibition is basically saying that the antibiotic is more effective.
Oh, I see.
Yeah. So that black line is zone of inhibition. That's what you want to be bigger than that break point,
Which one's a red line?
which is a red line. But-
No, which one? No, we can't see it.
Oh, on number 2 or number 7?
Yeah, so number 2. So the orange is the
Yeah.
intermediate.
And I don't love the way they did that, but that is what it's showing, is that when you measure that out, say you got, I don't know, like, well, for number 2, for amikacin, 21 millimeters. Let's say that's smack in the dab in the intermediate range when you look it up in your break point. The intermediate range is at 18 to 24.
Okay, so then it would be in the intermediate. Okay.
Exactly. And then I wish I had a table corresponding for number 1, which is the one that, they didn't indicate that there's an intermediate zone, so I don't know how to interpret that. So, and I could make up CLSI guidelines. But whatever.
The picture on our slide that has 2 and 7 is No. You have an old slide there.
What about it?
You got an old slide there,
Does
buddy.
yours say intermediate? Oh, okay, yeah, maybe I, well, seven to me looks like I would call that susceptible because the zone of inhibition is outside of that orange rim. But for 2, that looks like a solid intermediate and looks like 1. No. No, because that would be data, and we want information, right? The difference between data and information is one is, which is more useful? Information. So the breakpoints are the information. You will get both on that lab report. So, they will say SIR. Yeah, they absolutely will. Yep. Soup to nuts service. Yeah. I mean, it's not hard for the lab to sit there and look up what the CLSI breakpoints are. They look at the data. If it's an automated platform like the if they're doing Vitech or Phoenix or a microscan combo plate, we'll see in a second. That automated report says it has all the data and the information. It has like whatever the MICs are for that microbroth assay, which is the type of assay they use for those big platforms. And they have the breakpoints as well. So all that should be done for you. Your job is to look at that information and then decide what to do with it. In terms of, yes?
So ma'am, the breakpoints are predetermined values made by whoever's
CLSI.
like creating the drugs, right?
No. So big pharma makes the drugs.
Right.
Takes decade, right? And then when the drug goes through clinical trials, phase 1, phase 2, phase 3, that data has to be reviewed, and before it can even get approved, you need to know, that drug needs to be well characterized. Once it starts being used, all these ASTs are not just for the providers; they're also fed up for epidemiological purposes to CLSI, so they can use that, and they constantly review it. They review that data all the time. And just like I said, those breakpoints are constantly updated. As antibiotic trends worsen or improve or stay the same, CLSI is always updating breakpoints.
So the breakpoints could change.
They do, they can and they do change, yeah. So if you have a platform like a microscan that is, linked up to an LIM, some sort of server that tells you what the breakpoints are as it's interpreting the data, that has to be updated. That platform has to be updated every time CLSI publishes new breakpoints. That has to be updated. And labs, when they get accredited and audited for quality assurance, you can't just use last year's old expired breakpoints. You're getting accredited and reviewed based on your, you have the most current breakpoints always from CLSI. I was going to say something else about that, but I will remember later. Okay, so we just talked about those 2 assays. We talked about the one on the left. Now we're going to talk about the one on the right. I remember what I was going to say. So on this assay, the distribution assay, this too can be automated. We have instruments like Biorad makes an Adagio plate reader that will manually scan the zones of diameter, zones of inhibition as well. So that can be automated to an extent. But if you want to do high throughput, microbroth dilution series are usually the way to go. So that's the one we're going to talk about next. It uses a slightly different principle. Okay. I guess let's take a 10-minute break there, and we'll come back and we'll talk about microbroth dilution series.
Sure. Yeah.
be like,
It's like, no, I think like how she's talking about it. It's that awesome, like, private street at the office. And that isn't that like primary care. If you see the primary care, they're 60% restricted.
well, she was also saying you don't know how to do
Yeah, it's all based on documentation. So if you're the primary care, and it's bad, and you can't do anything. So what? So IDCs, like maybe has a program with they basically has mini docs and they can
They're
work
like
independently.
PAs if they already see active duty.
Yeah, independent ones. So like they
They probably go through like the
so like you said, like mechanism is like you give this antibody, they'll tell you why, tell them that's how
That's why they already see active duty.
So the Army used to have expeditionary medic, and they got rid of it. This was so they can prescribe this, and like only that has to happen at the end of the day. It's like whoever is over them just has to sign off. It's basically like family crisis. So that's because they're the ones who actually driving it for this person doing all those.
Well, we always are. We're better.
You're a medic. You still are.
Oh, yeah.
So your next set, you're going right back to being medic, son.
Back to operations. I'll be something Tuesday.
Like some program and that's good camping. She's not trying to do some full lectures over. She's going to get
That's like 2 hours. That one. But the Monday, not the Wednesday. I think the next one I think like the Monday.
So the next morning, just give them a front half. What? well, see if you go to school. See if I can like figure tell myself I'll do 240. I'm gonna figure out.
Talking to me?
I'll have the break capacity right now.
I've been rattling some rattles.
I was on my state yesterday and like they just fighting on politics.
You're not that simple.
Just like put my earphones on. I'm just freaking not. Like it's basically my father-in-law and his sister because like no my his sister, so like my wife's aunt. So like I was just put my earphones on. Like I don't have capacity right now. I got 3 brains on my fighting 4 places. Yeah.
What do you say when you're trying to speak by somebody? What do you say?
I say
You're doing something with bag. Bag. Yeah, bag. I need a big bag. How do you say the word bag? Okay. What do you put in your? I had a boss. I had a boss that was from. That sounds pretty boss. I don't like it. There was this girl from Wisconsin. One of the trains I went to. I was going to look at my big, and everybody was like, "Wait, you're what? My big? You're my magazine." Like I was like, "Your magazine? Big, your magazine, my big." I always drop my big. She's getting press.
We can't see your pointer, man. Seriously. I thought it was
Is it like a multicolored
Out on this cheeky little tropical trout. Short farm here should be able to drive the green if I do get it. Just fucking fix the right. I'm gonna grab my 69 degree, send it full throttle back.
Can you see that? Hey, can you see that?
I mean, it's not red. It's yeah. No, I can see that. I can see that you're drawing it. I just can't see like your pointer. It's okay.
It's the wrong way.
It's okay. I've dealt with it for 31 years. I can deal with it again.
Just go through the different all the pallets, the Home Depot card that.
Yeah. You can't even see the dot. No. When she goes up there, you can't see her dot. No. I see the black. Are you talking about when she's on it? Or she's doing the. No, when she's with her hand, I can see it. That's why she keeps pointing at it. It is super small. When she like points at something, like I can't.
No, it's because
She keeps saying. Most of the time I can't see it because it's so small. And it's light. That might be it. Or she would just draw on the slide. Yeah. Instead of pointing. Because she usually points to that slide over there.
Yeah, like even like in my waiver, because
But yeah, like these lines, those are all the same. There's no different tone. The only reason why I can tell is like this one, the blue is all the way outside, right? So I know like that's now going to be in the green. But like this.
Okay, guys, hang on. We've got 4 more slides in this deck, and then we will close this out and open the final deck of block 2. Okay, so we are gonna start talking about the microbiology assays, with the last couple slides. This is seeing what they look like. It's also designed to give you information about whether or not antibiotics would be good for a bacterial isolate. But this has the extra advantage in being able to provide actual MICs. So again, high throughput, you're gonna be loading most of these 96 well titer plates onto automated platforms that'll read those results out. You still have to allow time for growth and inhibition, so it's not like an immediate thing, but the results are read out and they're quantitative, and you take away user error a lot of times. That said, you can also do this manually if you want as well. What you're looking for here is a broth, so you're growing up the bacteria not on a solid agar plate, but rather in a suspension, a little microbroth, a teeny tiny well. And if bacteria can grow, as in they're resistant to an antibiotic, that well becomes turbid with their growth. Turbid meaning kind of cloudy. It's an indicator of bacterial growth. If you have an antibiotic at the right concentration that inhibits the growth, that well will be clear. Okay. So looking at how this works, let's look at the bottom first. The bottom has a schematic of what one of these rows looks like across across an entire row. So let's say you're starting on a well that's not even shown here, where there's no antibiotics, so there should be total growth. What happens if you try to put a bacterial isolate into a well and it doesn't grow even though there's no antibiotic in there?
Dead.
You screwed up something. Your bacteria should grow if there's no antibiotic. So that's a control, and it means that you have results you can work with. So you always have a control well where there's no antibiotic present. Like on this particular combo plate, I don't know if they put like where their control wells are, but there should be some sort of indication of them growing in the absence of antibiotic. But then from there, you go across and you do a dilution series, a twofold dilution series where you're increasing concentrations of that antibiotic, doubling them with every well. So in this example, you go from 0.06 to 0.12 to 0.25 to 0.5 and so on and so forth until you finally hit a concentration that's high enough to inhibit that growth visibly. That's the definition of MIC, remember? That minimum concentration. So the minimum concentration required to inhibit the growth of this bacteria visibly would be 16. That well becomes clear. It's no longer turbid. There's no bacterial growth in there, if that makes sense. This plate that we're going to look at initially is a super confusing plate to look at, but it's what we use in the lab when we want to be economical. It's a combination plate that uses the biochemical profile for identifications at the same time as it's reading out these dilution series of different antibiotics. So it's doing a lot. Up here, you remember some of these sugars that it's interpreting to see whether or not that bacterial isolate can use those sugars. So you're getting an identification profile. But what I want you to pay attention to is the fact that you're using that dilution series as well to get the ASTs out of that isolate. Okay? The way this particular plate is set up is actually going down in columns. So starting, if you can see in, what is this? Row 1B, should be, I know some of you can't see my laser pointer, but 1B, starting at a concentration of 0.25 mg per liter, and then increasing by twofold all the way down to 16 mg per liter. Yeah, okay. And that's for a particular antibiotic. In that case, the abbreviation is AM. That's probably amikacin or ampicillin, one of those two. And what we're looking for is when those wells go from being clear to, or when they go from being turbid to when they go to being clear. Here, this looks turbid at 0.25, but you hit the MIC at 0.5. So nice low MIC, and you've already hit a point at which the antibiotic can inhibit that bacterial growth. A couple takeaways. This entire plate is the same isolate. Keep that in mind. These are just different antibiotics in the columns. This is a carbapenem, teicoplanin, ceftazidime, cefoxitin, so on and so forth. Different antibiotics that they're testing for. So let's look at B. So we're looking at, I'm sorry, column 2. This is another antibiotic. What do you guys think? What's the MIC for this one? So in column 2, this is column 1 through 12 and rows A through H. If you're looking at column 2 here, which is testing for this carbapenem antibiotic. Yeah, you're saying the MIC is 8 mg per liter. That's the first well at which there's no growth, right? And that's that green arrow pointing to 8 mg per liter.
Is there a reason it starts so high? Not
Because
such
it's
a low concentration.
because against that antibiotic, that's the way it's been calibrated. Yep, each of these have been calibrated.
So, man, it's actually pointing at the letter G. What does that mean? Like the second row down, the G.
You're saying this is a G?
That's a G.
That's an 8.
Which one are we pointing at?
So
I'm looking at the second level down.
column 2, row B. This guy.
That's for what's up there. G is freaking.
So I will use my stupid pen function. There. It's so fine. Can you see that?
I can see that.
Yeah, I'm telling you, it is difficult. In this third column, now we're looking here, this column 3. Ignore these first couple wells, that black wells, that's a locator well, that's for the instrument, just ignore all these. But let's start right here, row whatever, A, B, C, D. So D3 is like playing bingo. D3, starting at 0.25, then we're going to 0.5, then 1, then 2, then 4. This looks like hypoplanin. It's a good antibiotic gram positives. What do you guys think? When do you stop seeing turbidity? 1. Yeah, right here at 1 microgram per mil, or yeah. Okay. What about column 4? Sorry, get my cursor back. Turbid, 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 turbid. Can you use that? Probably not. No, not effective. Not good. What is that? Ceftazidime or something like that. Some cephalosporin. Okay, let's just do a couple more. What about looking at column 6 here? Got turbid at 1. When does it become clear?
16.
Maybe 8, maybe 16. I don't know. It kind of depends. This is why it's good for an instrument to call these instead of human eye sometimes. But that's the principle. You guys get how that works and how it's different than the distillation assay? Okie doke. We'll see.
Jeez.
I didn't know I had a verbal crutch like that. It's terrible. Okay, I've got a mock-up of a plate. This is set up so it's a reading from right to left. Not trying to be difficult, but it's just the way the plate is set up. So now on column 12 over on the right there's no antibiotics. So antibiotic concentration gradient is going from greatest on the left to least amount on the right, where there's no antibiotic at all in column 12. So all of our rows have growth, which is great, right? It means we've not killed our bacteria, they're still viable. And then our twofold concentration gradients are increasing as we go left towards the plate. So we're looking at growth patterns. On row A, we've got an MIC already indicated. You can see that's a nice bright blue circle. It means it's clear. Okay, that's the MIC for that particular bug-drug combo. Move down to column B. Now we're talking about a different antibiotic. There's growth in every single well. What does that tell you? Don't use it. It's resistant. Absolutely. What about what about row F? Resistant to that antibiotic as well, exactly. What about the antibiotic that's used in C? What column do we have an MIC? Column 4. Good. Okay. What about, try a couple of these on your own. What about row D? Where's the MIC on that one? 10. And that's rather abrupt, isn't it? Sometimes it happens that way. It's very abrupt, like all of a sudden no growth. Row E? 6. Okay. Row G? 9, and then whoop, H.
I think it's 8.
8, yeah. Cool, okay, so pretty easy. If we're talking about breakpoints, again, these would be established, so there would be concentrations associated with all these that I didn't put on this mock-up plate. But let's say, just for kicks and giggles, in row A, we're using meropenem as our antibiotic in that, and our MIC is hitting right at 8 micrograms per mil. Okay, and our breakpoint is there, our breakpoint is at 8/1632 micrograms per mil. Is it safe to use that meropenem?
Yes.
Yes, because our breakpoint is greater than our MIC. Cool. Okay. Let's say our breakpoint for this resistant, for this antibiotic that the bacteria is resistant to is at whatever this concentration is. Let's say it's 2. Doesn't really matter, does it? It's resistant at all concentrations. It's one of those examples where it just doesn't, it has no efficacy. Let's say the breakpoint for the antibiotic in row C is less than the MIC. This is probably a no-go. I would say intermediate if it's landing on the MIC, but if your breakpoint is less than the MIC, it's just not going to work. Okay, so that's a resistant isolate. Okay, you guys get how that works? Okay. Resistant or susceptible? Susceptible. Resistant or susceptible or intermediate? Intermediate. Consult, yeah, intermediate probably. And I didn't do any for F through H, but you get the gist, right? Okay. Okay, so that's it for those 2 different types of assessing minimum inhibitory concentrations, and chew on those for a while. Let me know if they don't make sense. We can go over those, but these can be converted to applied questions. So, just saying, make sure you understand them. Okay, and then my favorite slide in the whole deck is right here. This is a great slide.
Yes.
It's talking about antibiograms. How many of you guys have ever heard of antibiograms and or seen one? Oh, thank you, sir. Yes, there's one person. Okay, have you actually used one to guide therapy? Okay. Okay. Well, what these things are nice summary tools that take into account kind of all the AST data that's been generated from the lab for a given section over a given period of time. So how this is arranged is we look at all the important, clinically important, significant isolates that have come through that hospital. Let's say we're talking about Methodist Hospital or BAMSI, even better. And they are looking at all these major pathogens that have come through that have been identified as clinical isolates in that lab. And let's say it's for calendar year 2024, so we have a finite period of time for this data. They have it arranged by their gram negatives and then their gram positives. And then in this column next to it, it's the total number of isolates that they've seen from each one of those types of bacteria. So we look at the gram negatives. The one that they've identified the most in that clinical lab is which one?
E. coli.
E. coli. They've had 346 E. coli isolates in that year period. For the gram positives, what's the most commonly identified isolate that they've had? MRSA, 528, about double what they had for MISA, or sensitive Staph aureus. So, okay, the more isolates, the more power, the stronger the data and the correlations that they're generating. And also recognize that when we talk about escape pathogens, a lot of those escape pathogens are on this list. And they're on this list for a reason, because we're concerned about those bacteria and their antibiotic resistance. We talk about Enterobacter cloacae, it's on that list. Staph aureus is a gram positive, it's on that list. Klebsiella pneumoniae, it's on that list. And so on and so forth. Acinetobacter pneumoniae, Pseudomonas aeruginosa, Enterococcus. So these are important because their resistance patterns are concerning. So that's what we have in our rows. In our columns here, we have our antibiotic classes that we've talked about in previous lectures. Some of them we would expect would be mostly resistant, depending on the class and what you'd expect for the spectrum of activity. But there are also some surprises here. So let's say you identify from your patient they have an E. coli infection, and for some reason you want to prescribe them fluoroquinolone, like ciprofloxacin or levofloxacin. What would you say would be the chances of that working out well? I mean, it's hard to see from back there, so you might have to expand your own screen to see that. But and how are you getting that information? What are you looking at? Okay, so for regular E. coli, not ESBLs, but regular E. coli, 16. What does that mean? What's for those of you who can see my laser pointer? No. So 60% of these 346 isolates are susceptible to those fluoroquinolones. So,
Can you do it over here?
yeah, sorry. I feel like a weatherman. So we're talking about just regular E. coli. So there's 346 of them over there. Following this line across, let's say I wanted to treat my patient with a fluoroquinolone because I had Cipro or levofloxacin. Only historically, the data from the lab generated from that year-long period of 2024, historically only 60% of those E. colis were susceptible to those fluoroquinolones. They're color-coded too. What do you think yellow means? Probably don't want to use, right? Historically, there's a significant amount of resistance to those fluoroquinolones with E. coli.
In what case would you use those instead of the ones that are green?
Well, that's kind of the point. So, say whatever reason is your favorite antibiotic, whatever silly reason you wanted to use Cipro, you consult the antibiogram, and let's say this is an urgent case, you need to get that patient treated, whatever. You might steer away from that in favor of one of these green categories, something like 100% susceptibility to ertapenem or meropenem, one of those carbapenem drugs. 100%
With something like
susceptible.
with something like insurance and the cost of the drug, hey, would that be like a factor you consider? Like one drug costing more than the other, so I'm gonna give you the
I mean, it's a serious question. I just don't know for sure. Potentially, yeah. But I think that would be low tier relative to other considerations. There's so many considerations for antibiotic selection.
So this data, is it just from your lab from your facility that you're working in?
Yep.
And it's going to be different, obviously, from what
Exactly. So use the example of BAMSI, because this is not an optional thing. You are required to compile antibiograms annually, sometimes quarterly, whatever. But this is one of those inspectable items when you get inspected and you have to show your antibiograms because they're used to guide patient treatment when you don't have time or when you just want to see trends. You have your infection control team that will be reviewing antibiograms for that year to year. Go back to 2023, 2022, 2021, see what's happening over time with E. coli resistance of fluoroquinolones or something else like that. Very valuable tools. And then this also, it's not just for the providers, but this also gets sent up nationally to other organizations that compile data and monitor all of our antibiotic resistance trends for the United States as well. So this data definitely gets some miles on it, but when you guys get to your first assignment or whatever, if you get a chance to look at that antibiogram, do. You can learn a lot about local resistance trends, and you can teach yourself a lot about them. And then when you PCS to your next place, you can compare resistance from place to place because these do change. Practices impact or influence antibiograms and local resistance.
So this doesn't take into consideration of like the strength that they're testing resistance, but it doesn't talk about like how much they're actually giving of like a concentration of the specific.
No, this is like metadata, if you will. It's like a summary. If you wanted to drill down, say you wanted to pull all the MICs that came off your microscan for that year, you could do that. You could go, because the lab does not throw away that data, they keep that data. But this is kind of the important cream layer. What you really want, this is enough to tell you whether or not there are trends that are going well or going poorly. Okay, any other questions on this deck? Okay, oops. Let me switch over decks. This is the last slide on there. Oh, it's a little antibiotic discs. By the way, guys, if you're in a resource limited setting, this is considered to be the way to go. It's very cheap to do that disc diffusion assay. If you're wondering why would you ever prefer to do that than microdrop dilution? This is very inexpensive. So they do this in developing countries a lot. The problem with this, though, is those discs have to be in pristine condition. It varies from lot to lot, from manufacturer to manufacturer. They have to have the right temperature. You have to plate them just right. So there's like a trade-off with using those disc diffusion methods. But they are good in a pinch. Okay, I'm going to shut down this deck and I'll pull up the other one. Feel free to take a 5-minute break if you want.
Questions from one thing? Yeah.
Hey, look, you're gonna put the wrong way. You're gonna call the farmers quick.
You get one wrong, you get four wrong.
They get very mad if you put the wrong way. Oh, not making.
that's not your job. I think they probably suck.
No, just we just read it. I thought you said like. I meant making. No, I thought that.
Someone probably.
Yeah, it was CPS like weird. It'll be like all week. I don't think we're gonna get it today. Start tomorrow morning. Mine's still 5% like
Tommy John. What's that? It was on out. You see it? Did you see it? My buddy did it in high school. Just trying to prove to everybody you could throw it. He's our catcher. Throw it from home plate over the fence. Did it the first time. I can do it again. No, don't. Did it again. Ooh. Okay. Then play Ultimate Frisbee like 2 weeks later. Tore it again.
You gotta do virtual.
Laid out with that arm. Hit and it just full, like all of a sudden just busted. His mom was so pissed. Guess who the EENT instructor is?
what it is, like what they're. I was gonna ask is you're asking about the bacteria or the
Who remembers something? This guy. 10 points to Gryffindor.
Okay. Ready or not. Alright, so Thomas got this question right, but on this opening salvo slide, what are we looking at? What do you think? It's aesthetically pleasing, beautiful artistic image. Neutrophils throwing out their little mitosis. Yeah. So blaze of glory, suicidal moment right there. Target bacteria getting completely obliterated. It's just awesome. Awesome. Okay, so in this deck we are talking about host-pathogen relationships and kind of trying to develop a more nuanced understanding before we start into block 3, which will be the next lecture. Well, not next lecture, but right around the corner next Monday. We had a really solid intro for the host side, the immune side, but now we're going to talk about the response, the clapback from bacteria and other pathogens, like how they're dealing with all these things that we do. So this is about what's that? It is, yeah. For me, that's very pop culture. So yeah, this is kind of like what the bacteria do to thwart what we do. We're going to start off with the usual terms, sort of rote memorization stuff a little bit, terms that define these host-microbe relationships. The characteristic and conditions, this is a little bit more conceptual, so if you don't like conceptual stuff, this might be a little painful. Attributes and characteristics, pretty straightforward. When we get down to exotoxins, endotoxins, microbial enzymes like invasive enzymes, things like that, that's really first order stuff. Easy to memorize. I'm not even mad at you if you memorize that stuff, that's fine. Then we will talk about a little bit more about what the host does, but we've already talked about that, just a little bit of a quick summary, again, of what the host does. And then finally, the last part of the deck will be some terms about epidemiology that we'll use throughout the course when we're talking more about outbreaks and things like that, epidemiological terms, as well as just transmission of infectious diseases, shedding, things like that. All right, so first things first, we recognize that all of us, we've made this point before, but no one is in a perfect state of health, and we are constantly bombarded and encountering different microbes. 24 hours a day, 7 days a week, this never goes away. We always have some sort of minor infection. Some of those are kind of on the brink sometimes of spilling over and becoming problematic for us. But this is best thought of as a spectrum between health and disease. Much like this, if you've been to career course maybe or ILE and you study the conflict or competition continuum as a spectrum, when you go from friendly relationships to all-out hostility, open warfare, also a spectrum. You can kind of apply this in easy geopolitical analogies if you want. If you think about our allies versus perhaps nations that we are and have historically been hostile to. Or if you prefer to think of it in more intuitive terms like your friendships or your relationships or your enemies, that's another way of thinking about host-pathogen relationships. Sometimes you are friends with someone from start to finish, and sometimes, unfortunately, you start off liking someone and you end up despising them. Okay. So that's sort of the analogy here. You have commensals, and given the right opportunities, the right conditions, those commensals can sometimes be extremely pathogenic, can cause disease, can even kill us. And then there are, I guess, continuing that analogy, there are people that we hate from the moment we meet them, and we will always hate. Those would be sort of analogous to true pathogens, like malaria, perhaps, and HIV. Like, there's never going to be a friendly moment between the host and malaria and HIV. It In terms of how we define these things, sometimes these terms are misused a little bit, but the umbrella term that we use to describe all relationships, close relationships between microbe and human, is symbiosis. These are our symbionts. It just means that we are living in close association to them. It's not a loaded term. There's nothing here in this root that is positive or negative. There's no connotation there, just living together, for better or for worse. When we start loading up these terms, whether or not we get something out of it, we get these sub-terms that are types of symbiosis. Mutualism is pretty intuitive. We both get something out of it. That's nice. Commensalism is what you hear most of the time when we're talking about commensals on and in us. That it's sort of a blanket term. You don't hear the term mutualists, but sometimes mutualists are what they are and they're called commensals. But commensals, strictly speaking, means that it's a net neutral. There's no gain and there's no negative outcomes of that reaction. Most of what we're studying in this course, unfortunately, is the bad stuff, the parasitism, and ignoring all the good stuff that goes on, which is the vast majority of the interactions. They're either mutualistic or they're commensal relationships. But we wouldn't be here if we didn't have a reason to be, so we're going to study all the bad things they can do to us. In terms of the lay of the land and normal microbiota, we've already talked about where we find bacteria. We find them in our GI tract, we find them in our urogenital tract, and we also find them on all exposed surfaces. So all over the body, this is just showing the exposed external sites of the human body that are colonized with different bacteria that are normal microbiota. And the point here is that in each one of these different niches on the human body, there's a different composition of bacteria living in those different sites. This is also kind of colored, I like this is from the Murray textbook. It's color-coded by site as to whether it's a sebaceous site, like an oily site like the glabella up here between your eyes, or a dry site that's red, so like the buttock, for example, is considered to be dry, whatever. So that has its own ecosystem. And then there are moist environments like the axilla, inguinal folds, what other moist areas do we have? That's color-coded in blue. Ear canal is a little bit moist, I guess, the back sometimes. Each of these has different compositions of bacteria. That's the main thing. For most people, about 95% of our normal microbiome is shared. So we all have a lot of Staph saprophyticus on our skins. Coriniform bacteria, those are common commensals that we all have. If you drill down on an individual basis, our microbiota will start differing to the point that it becomes like a fingerprint for you as an individual. So we might have similar lifestyles and similar diets. We might even be related. You might be my brother or sister, but it doesn't matter. None of us have the exact same fingerprint of microbiota. That's called the secondary microbiome, where it starts differentiating out and it gets to be pretty specific. When do we become colonized? At what point do you think in our life do we pick up all these passengers? When? During infancy? Okay.
During birth. I say birth.
Yeah, during birth is when you pick up the majority of your microbial load from the mom. Yeah. So when you're a fetus, when you're in utero, that's a pretty sterile environment. Amniotic fluid is pretty sterile. You're not supposed to be exposed to much during that time period. But once you're born, game on. Once your vaginal delivery, you get colonized with a whole bunch of stuff. Cesarean section, you miss out on that. And this is sort of by evolution how we've been getting colonized and how everything that's born gets colonized. So this is a normal thing and it's a good thing. Unless your mom has like herpes strep or herpes simplex virus or something that can be transmitted during birth, it's normal to get colonized. And that fingerprint grows and develops a little bit as you mature on into adulthood, but it doesn't change a whole lot. There are minor changes, and those changes would be things like personal hygiene, for example. That can go both ways. If you are super clean, fastidious, you want to shower 3 times a day with antibacterial soaps and dry out your skin, that can be too much, right? That can be detrimental. You can start compromising the integrity of your skin as a barrier function to oils that have antimicrobial peptides. That's not good. And obviously in the other direction, that's also not good. If you do not bathe ever, and you don't take care of yourself, that can also be gnarly in a bunch of ways. Diet is one of the most obvious factors that influences the type of microbiota that you as an individual have. When we talk about probiotics versus prebiotics, what's the difference? What do those terms mean? Or are they the same thing? Yes, ma'am. Okay, yeah. As she said, probiotics are the bacteria themselves, and prebiotics are basically the substrate or the food that the bacteria eat. So what would be an example of a probiotic? Yogurt. Everyone always thinks about yogurt, right? It has like 10 billion CFUs of Lactobacillus acidophilus per mil, or whatever the unit is for that yogurt. Honey shouldn't have a lot of bacteria in it. It shouldn't be like a probiotic source. Yes, that is true. But it shouldn't be a source. Like, in fact, honey is associated with some pretty bad diseases that you do not want, like botulism, Clostridium botulinum for infants. It's a major no-no for feeding infants that. But other fermented foods, if you're talking about like sauerkraut, that's considered to be a heavy probiotic. Kombucha, yes, mother yeast, absolutely, very hippie. What about some prebiotics? No, that's super cool, I like it. But what are some examples of prebiotics that you would eat? Yeah. Say again? Yeah, exactly. So a lot of plant materials like onions, artichokes, bananas, a lot of the fruits and vegetables you eat will have in them material that you cannot break down yourself. Your gut, the enzymes in your gut are incapable of breaking that down. Enterobacteria, they can. They have the enzymes that can do that. So they're basically using that really healthy food as their own substrate, and then you benefit because you get the vitamins that they synthesize as a result. Vitamin K, types of vitamin D, etc. So a nice mutualistic relationship there. With water sources, you wouldn't necessarily think about it as being a big factor, but whether you're not on municipal water or maybe living out in the country and you have well water, that can make an impact. If you drink water that is heavily chlorinated, they always say that's not bad for you, and it may not be bad for you, but it could be bad for the 100 trillion residents in your gut, right? They might not be able to tolerate that chlorinated water so much. And indeed, like if you swallow a huge amount of chlorinated water at the pool, you could get sick after that. And the reason for you getting sick might be because you just completely like battered your intestinal flora. Medicines, this is pretty intuitive, especially antibiotics, but other things as well. Anything that's going to affect or alter your metabolism, broadly speaking, could have an effect on your normal microbiota. Exposure to environmental toxins, heavy metals in particular, like arsenic, lead, those things can also have an effect on your microbiota. In terms of just the numbers game, the number of bacterial cells in our body have numerical supremacy over our own human cells. It's kind of mind-blowing. But when we talk about order of magnitude, they're at least an order of magnitude greater than us. It's 100 trillion versus 10 trillion in favor of prokaryotic cells. So they are only between 10 to 100 times smaller than we are. So that is a huge amount of us that is microbial. Really, really important. In terms of how they evolved with us, we've had bacteria in us since long before we were humans. This is an evolutionary thing. It's not just humans, but most mammals, I can't think of any that wouldn't use bacteria in their guts as a hidden organ. It has a function and a purpose. In order for that to be a nice relationship that we can sustain long term, what's a common thread for all nice relationships? Whether bacterial or just interpersonal human relationships. You're nice to each other. Yeah, so you're either nice or at least not nasty to each other. Otherwise, it's not going to work out, is it? No. So that relationship is either going to be mutualistic or it's going to be commensal, one of the two. But you can't be hurting your host and expect for that host to treat you nicely back. Most of these bacteria are going to be not causing any problem at all, especially if they stay where they're supposed to stay. We had that slide that showed different niches on the body being occupied. But what do you think happens when you have a gut bacteria go someplace it should not go, because it's not welcome? Our immune system's going to freak out for one thing. It's going to put it back in its place because it's supposed to be in the gut. So if it ends up in the urogenital tract, that's going to be a problem. That's a common source of UTIs. Our GI bacteria somehow contaminate our urogenital tract and we have issues. Or we have a perforated bowel through trauma or something like that. Those gut bacteria get out and cause all sorts of very serious problems. We've seen pictures of, or cartoons or schema talking about gut bacteria before, but this one kind of nicely summarizes the role of healthy bacteria versus, the role of healthy bacteria in a gut versus a gut that has been damaged and has reduced populations of healthy bacteria. In this cartoon, the healthy bacteria, use my cursor here, but the healthy bacteria are purple, where the guy is right here. You can see they're very abundant. It's a nice thick mucin layer. I'm covering up the slide a little bit for you guys, but this is what we want, right? We want a lot of good bacteria occupying those niches and limiting the amount of pathogens. Oh, that's too much. Let me erase some of that. But limiting the amount of pathogens that come into, or come across those mucosal surfaces, those gut-associated lymphoid tissues that can penetrate across. In depleted microbiota, you don't have this nice layer of bacteria in the mucosal tissues. So these undesirable pathogens, the ones we do not want, the ones that are coming into our body mostly through the food we eat, not endogenous, but through the food we eat, are now able to penetrate that intestinal barrier and cause potentially some serious problems. So super important role there. This is sort of the trade-off, or we've talked about this, but just a summary of some of those trade-offs from what we give and what the microbes give back in return. We give them some real estate. We might tithe some of our food to them in terms of prebiotics. We give them protection from competing species by our immune system, right? Our immune system will clear out some of their competitors. And in return, they train our immune system like we've talked about. They train our immune cells not to overreact or be overstimulated. They provide metabolic functions, so they will produce some of those vitamins that we can't produce ourselves. And then they will also do their own thing in terms of protecting us from undesirable bacteria. They prevent the outgrowth or the overgrowth of undesirable bacteria. Protect that niche, protect their territory. When you have opportunistic infections, that's just like it sounds. It's something that is unique to circumstances and conditions that shouldn't be. There are some triggers that put us in jeopardy of having opportunistic infections from these bacteria that are normal commensals that usually aren't doing us any harm. Some examples of things that can cause opportunistic infections from otherwise friendly commensals would be disturbances in the normal microbiota, like you take a broad spectrum antibiotic for something really serious or something not serious, whatever. You take a broad spectrum antibiotic and it wipes out your normal flora in your gut. Then you get what's called dysbiosis, which is an imbalance of those gut bacteria that allows the overgrowth of things like Clostridioides difficile and other bacteria that are really, really dangerous. Hormonal changes, like when you are during pregnancy, you can have hormonal changes that cause disbalance between microbiota, can cause dysbiosis. You get an increase, a lot of pregnant women get UTIs at a higher frequency because of those hormonal differences. Chemical changes, like if you have a patient that's undergoing chemotherapy, that will screw up their normal balance of bacteria. Sometimes organisms are introduced into ectopic body sites. What does ectopic mean? Like if you have an ectopic pregnancy. Yeah, somewhere you're not supposed to be. Yeah, ectopic pregnancy is when you have a pregnancy that's starting in a place where it shouldn't be, and same with organisms that are coming into an ectopic site. If it's supposed to be in your gut, it shouldn't be in your bladder, probably, right? That would be a bad thing. So that can be caused by all sorts of things, traumatic injury and surgery, or obvious ways you can introduce bacteria. If you have trauma, it's not just the fact that whatever is penetrating into your body, let's say it's like some projectile penetrating your body, that's certainly not sterile, is it? It has bacteria on it. But also, if it's a penetrating issue or penetrating injury, it's just ripped through your flesh. So your endogenous skin flora is also coming into your body as well. So you're having a whole bunch of different microbes entering sites that should be pretty sterile. Infections from endogenous bacteria. When we say endogenous, what does that mean versus exogenous? Yeah, endogenous being a commensal of some sort, somewhere, some appropriate niche, versus exogenous, just more in line with what I was talking about with a penetrating injury, for example, or the bacteria is coming from the outside, it's not on you already. Or like a waterborne and foodborne bacteria, exogenous bacteria coming in. So that can also cause opportunistic infections, these types of introductions of bacteria. And then lastly, immunological compromise. When you are immunosuppressed, you're on immunosuppressive drugs for like an organ transplant, tissue transplant, something like that. You are super old, super young. Physical and mental stress, that can impact your immune system. If you're stressed out chronically, if you're not getting enough sleep, if you're not eating well, if you're not taking care of yourself, all of those things can dampen your immune response and lend itself to opportunistic infections that wouldn't normally be issues. This figure on the right, what's showing here is a cartoon of a patient who's been on an antibiotic, and her normal flora looks like it's been compromised. There's dysbiosis here, and that's caused the Candida albicans, type of yeast that colonizes a couple different parts of the body that we'll see in a second here. It's caused an overgrowth, an opportunistic overgrowth of Candida albicans. So that yeast hasn't even moved to another site, it's just been allowed to overgrow because this antibiotic's wiped out competing normal flora. And as a result, this Candida albicans proliferates and you can get opportunistic infections that you wouldn't normally see, like thrush, oral candidiasis. You don't see that in normal healthy people. It's an opportunistic infection. Yeast growing on and in the oral cavity like that, that's usually associated with immunocompromised folks. In terms of what we call a pathogen and how we refer to pathogens, this too is probably best thought of as a spectrum from mild commensals all the way up to pathogens. But this is sort of a hotly contested, oftentimes debated spectrum as well. We have what we have talked about before, what we consider to be true pathogens, like HIV and malaria. But we also have on the other end of that spectrum are commensals that have very few virulence factors, very few weapons, if you will, that can be used to damage our tissue. Like Lactobacillus casei, Propionibacter acnes, that's a bacteria that's associated with causing zits or acne. They don't have a lot of virulence factors, which we'll define in a while, but they don't have a lot of ways to directly damage us. But even those friendly ones can become pathogens under the right conditions. If they are in the wrong sites and if we're immunosuppressed, they can still cause infections. So because of this kind of nuanced relationship, there's a helpful model that is sometimes used to deepen our appreciation for those nuances. It's called the damage response parabola. And basically what it does is plot the host response on the x-axis, x-axis on the bottom there, against the severity of infection on the y-axis. So a good example is going back to that yeast example because we just talked about it a couple slides ago. With yeast, Candida albicans in particular, that is considered a commensal for the most part. It colonizes our gut in really small numbers. It's not supposed to be highly prevalent there. It's in our mouth. It's in our urogenital tract, especially for females. We have a lot of Candida albicans. So, yeah, and it's even on our skin. So it's kind of all over the place as a commensal. But under different circumstances, it can certainly become pathogenic. One of those conditions that we already talked about was thrush, the oral candidiasis, right? So if we look at this first damage response parabola, we're seeing, let's look at the post response from weak to strong. If you are immunocompromised, you have a weak immune system, what can happen is the normal yeast in your mouth can overgrow and you can start getting some pretty significant damage. You see that. Where normally, if you have a strong immune response or even a normal immune response, it's a beneficial relationship. Like you get something out of those yeasts that are in your mouth normally. So this is detrimental only when you have some sort of immunocompromised system and you start getting damage. Now take the same organism, we're still talking about Candida albicans, but let's move the niche over now. So now we're no longer in the mouth, now we're in the bloodstream, where there should really not be any microbes, right? That's kind of a sacred and sterile site. But let's say we get some yeast introduced into our bloodstream. That's never going to be a beneficial thing. It's always going to be damaging. But again, if our immune system is somewhat compromised, then it can be catastrophic. It can be fatal. We cannot clear this. Continuing to move on, now we have two examples of overreactive immune systems now causing problems, where our own immune system is the problem itself, or can be the problem itself. So this is what we consider to be immunopathology versus the same types of damage we'd expect if we have an underreaction from the immune system. So in this case, we have intra-abdominal candidiasis, where let's say we have a perforated bowel, and the Candida albicans has been released into that intra-abdominal cavity. That's another situation. It's never going to be good, but if you handle it properly, if your immune system is just right, you can limit damage. If you underreact, it gets to be very, very serious, potentially fatal. And if you overreact, you could have septic shock, right? You could have cytokine storms and septic shock. And then finally, this last example is GI candidiasis. So in this last example, there's nothing wrong with the bowel itself, at least it's not perforated. So the yeast are causing a problem, but at least it's not spilling out into the intra-abdominal cavity. In this instance, if it's perfectly handled, it might be a little bit less damage, but again, we see the same extrema for an over-response and an underreaction on the immune system. Okay. So all that is just to say that there should be a more nuanced way of understanding host-pathogen relationships. Another example is with COVID, which we all lived through, and we probably all heard people talk about their own specific anecdotes about, I was exposed and I was hardly sick, and how can you explain this? It's probably something along the lines of their host immune system and how it was handled. All these paradoxical anecdotes that people have about infectious disease experiences. This is just a little bit more nuanced. Okay. Time to go. Okay, well, it's 2:50 right now, 4:50. I know you guys don't have research evals, so we'll pick up on this slide tomorrow at 10 o'clock. And yeah, see you then. Hope you guys have a good rest of your day.